everyone. It's really great to be here with you guys. Uh, I really appreciate all the effort done from the Excellence in Endodontics team to make this great event. I want to start saying thank you, Dr. Ahmad Madarati, for inviting me here in this event to share knowledge. So I will give you some information about me. I am Dr. Wael Ashtar. I'm specialist in endodontics, and I'm coming here from Syria, from Aleppo. This is my beautiful country, and actually everything is good here, and we hope that endodontics is moving forward in Syria. I'm 28 years old, and this is my beautiful clinic. I do love it, and actually I spend about 4 days a week in this room, the clinic. I'm teaching in university, Aleppo University, Faculty of Dentistry, and actually I spend in my clinic time more than I spend at home. I'm going to try to present something about working length in endodontics in this presentation. What will be covered today is working length, apical point, cemento-dentino junction, electronic apex locator, radiographs. Today we are going to talk about these points. We will focus on apical point, the cemento-dentino junction, the apical construction, and the electronic apex locator, and we will be able to know where should we stop our preparation, our instrumentation, and our obturation. So guys, if you are ready, let's start. First of all, we know all of us do endo treatment in our clinic. We face some problems, some mistakes. For example, overfilling and underfilling. Here in this case, have a look to this case. And by the way, it's not my case, it's from internet. This case of overfilling, here I think it's gutta percha or maybe broken instrument, whatever. But here in this overfilling, there's irritant the periapical tissue, severe pain. Absolutely, the patient had severe pain, and periodontal ligament breakage. Underfilling. This underfilling. Wait a second. I need a pointer. Here, root canal filling ends here, but the root ends here. So I have 3 or 4 millimeters without any preparation or any cleaning. This space, 3 or 4 millimeters, incompletely cleaned canals, infection, microorganisms, inadequate instrumentation, inadequate irrigation, inadequate shaving, inadequate cleaning, and inadequate obturation. So this space, even if it's just 1 millimeters, there's a million or billion of bacteria and microorganisms. So it's a poor treatment, and both overfilling and underfilling is really bad for the patient. But why this happened? Why overfilling and underfilling? This all because of working length determination. So today we are going to talk about working length. What is working length? The definition is the distance between the coronal reference point and the apical point. So we have 2 points. The apical point, we will talk about this apical point and apical construction, radiograph, apex, blah blah blah. And we have the coronal reference point. For example, we have anterior teeth and we have posterior teeth. For example, in anterior teeth, like this first photo, this is canine, I think. The highest point of the incisal edge is always the coronal reference point. So in this position, I will put my rubber stop and take my working length. But in posterior teeth, different. Each canal have its own reference point. What does it mean? For example, if I'm working on premolar, upper premolar, 2 canals, I have buccal canal and palatal canal. The buccal canal, the coronal reference point will be at the buccal cusp, for example, whereas the palatal canal, the coronal reference point will be at the palatal cusp. So in posterior teeth, each canal have its own reference point. But in anterior, no, just the highest point is always the highest point of the incisal edge is always the coronal reference point. Coronal reference point must be easily visualized, easy to see, and stable, and can't be fractured or lost. How can't be fractured or lost? For example, if I'm working on a lower molar, for example, and there's no distal wall, and I put temporary filling, I take my working length. It was, for example, 20 millimeters. This temporary filling in the next visit, this temporary filling can be fractured or can be lost. So I will lose my working length. It will be maybe 70 or 80. Why? Because it's temporary filling. So the best coronal reference point must not be fractured or even lost. The rubber stop. The rubber stop is very important in K files. It must be visible reference for working length. It must be stable during preparation. Yeah, it's very important. When you put your rubber stop in the file, must be stable during preparation, during scouting, must not be movable, and this rubber stop must be positioned perpendicular to the file. Can't be inclined. Why? Let's think why. Why the rubber stub must be perpendicular to the file and can't be inclined. Actually, the answer is here in this slide. For example, here we have 3 cakes or 3 photo of K files. Let's talk about the middle one. Here is the rubber stub. The rubber stub here is perpendicular to the file. So I have two sides here. This side is 50 millimeters and this side is 50 millimeters. So here I am, everything is okay here. But for example, in this case, we have inclined rubber stub. So we have two sides. This one side and the second side. This side is 50 millimeters, whereas this side is 60 millimeters or 70 millimeters. So I have two, one 50 millimeters and one 60 or 70 millimeters, and this is actually a big problem if the rubber stop is inclined. The position of the rubber stop here, as we see here, in this situation, for example, this is the same of the last slide. Here we have, for example, here the rubber stop. The working length is okay here, but whereas in this situation there is an over instrumentation or over preparation. The apical point. What is the apical point? Where is the apical point? Where is the apical end? What is my working length? Where should I stop? And this is very important. Is it apical foramen, or is it anatomic apex? Is it radiographic apex? Is it apical construction? A lot of thoughts, a lot of information, a lot of articles, a lot of research. So guys, if you just write on Google Scholar just apical foramen or apical construction, you will find maybe 83,000 results, a lot of articles about this part, apical point. For example, this study or this articles in 2003, the cemento-dentino canal junction, the apical foramen and the apical construction, evaluation by optical microscopy. The conclusion of this study or this article, the ideal root canal filling is one which is performed three-dimensionally and that completely obliterate the area from the root canal to the cemento-dentino canal junction. The cemento-dentino canal junction is the point where the cementum meets the dentinal canal, the cemental cone extending from here. The cemento-dentino junction is simply the point at which two histological tissue converge inside the root canal. What does it mean? This means, guys, that cemento-dentino junction is the best and perfect position to endure preparation, to endure instrumentation, and to endure obturation. but actually this position can't be detected clinically. Impossible. It's just histological. So actually this point is useless in the clinical practice. So for example, here this another article from Jordan from New Zealand. Review electronic apex locators. The conclusion of this article is that the cemento-dentino junction is a practical and anatomic termination point for the preparation and obturation of the root canal, and this cannot be determined radiographically. As we said, that a modern electronic apex locator can determine this position with accuracy of greater than 90%. Wow, that's a great actually. But by the way, we have to know that electronic apex locators give us the apical construction exactly, not the cemento-dentino junction, because cemento-dentino junction can't be determined clinically. It's just histologic. We have two figures here, figure A and B. Here we just to know that the anatomy of the apical foramen changes with age. Figure A, for example, figure A shows that the apex of a younger person and the changing with the years. And here's number, or figure B shows this information. We have number 1, number 2, and number 3. We will talk about number number 1. This is the tooth apex, or we can say this is the radiographic apex. We don't need this point actually, guys. We have number 2. This is the apical foramen, or the major foramen. I don't prefer to stop my cleaning or stop my preparation in this position. And we have number 3. This number 3 is the apical construction, or we can say the minor foramen. This is the best point to end your preparation, the best position. Here we can say the cemento-dentino junction is here maybe, or here, very near to apical construction. This illustration is from Dammer et al. 1984. It's very useful actually. Here are some types of construction. For example, we have here type A, traditional single construction. It's 46%. Type B, tapering construction, 30%, and type 3, multi-constructed, 90. Type D, parallel construction. It's rare cases actually. Have a look, guys, to this photo, especially this one at the right. Actually, I always use this image to my student to teach them, to make him know what is the difference between apical construction, apical foramen. If we want to talk about this photo, let's say this is the root canals, or this is the pulp tissue. And by the way, the cemento-dentino junction in this area, the pulp tissue will end and the periapical tissue will start. So, as I said before, cemento-dentino junction is the best position to endure preparation and obturation, but you can't detect this clinically. Here we have the apical construction here, and the minor foramen, sorry, and here the apical foramen, and here the radiographic apex or root apex. Let's have a look to this. This is extracted teeth actually. Here the doctor is follow the radiographic apex. He tried to reach to the root apex. Maybe he used the X-ray radiographic, but I don't think he used the electronic apex locator. Here the difference between the anatomic apex and the radiographic apex. It's not the same, guys, by the way. It's not the same. There's a difference, maybe 2 millimeters, 1.5 millimeters, sometimes 3 millimeters, but it's not the same. This case done by me, have a look to this point. This is anatomic apex, and this is the radiographic apex. So there's a different distance between them, maybe 1.5 millimeters, and here the anatomic apex is lateral. not at the end of the root. So not every end of the root is the anatomic apex. Sometimes it can be lateral, exactly like here. This case, I did this case. This is the first or second premolar, second upper premolar, yeah, with two canals actually. And I used electronic apex locator to make this treatment. And when I make X-ray radiograph, I confused. There's maybe 3 or 2 millimeters away from the apex. Sorry, guys. And this another case, second premolar, lower premolar. Yes, I did this in electronic apex locator, and when I take X-ray radiograph, I reach here, whereas you think the apex is here, but when I make obturation, have a look, the apex is lateral. Another case, molar, lower molar. Here the apex is lateral too. Now we will talk some methods of working length determination. We have maybe 4 or 5 methods. We will talk about radiograph, the first one. The second one is electronic apex locator. Third one, tactile sense. Fourth one is paper point test. And fifth one, the last one, is patient's pain perception. And I don't like this method. Let's start from the first one, radiograph. What is radiograph? Radiograph, this is the most popular working length determination method. Taking radiographs with an instrument inside the canal. Actually, it's the most popular, and most of all use it. Okay, what is the technique of this method? The technique, we put K file number 10 or number 15 in the canal, and we do X-ray radiograph, and we will see. After that, we will minimize 1 millimeters from all the length, and that's what we called our working length. Here, this is the illustration. I made it just to make it obvious. Here, the K file, I put it inside the canal. I take an X-ray for radiograph. This is all my working length. No, it's not my working length. Actually, this is the radiographic apex, not the anatomic apex. And I always want to reach just to the anatomic apex, not over. So I minimize here 1 millimeters, and this will be my working length. If the radiograph is far from radiographic apex, more than 2 millimeters, it's better to redo radiograph. Actually, it's my opinion. In this case, for example, in this case, I'm scouting. I take the X-ray radiograph. I think it's 2 millimeters, but I'm not precise if it's 2 millimeters or 2.5 millimeters or 3 millimeters. So if it's more than 2 millimeters, I prefer to redo radiograph again. And we need absolutely high quality radiograph. We have to note that the radiographs, the X-ray radiographs, gives us always the radiographic apex, not the anatomic apex. What does it mean? For example, I do this this extracted teeth, premolar. I put a K file number 15 in each canal. Okay, I reach to the apex, let's say the apex, just the apex, the root apex. I made X-ray radiograph. This is my X-ray radiograph. It's perfect. I will think that I am in the at the apex and everything is okay. But under magnification, microscopic magnification, I will see notice that it's over half millimeters. Why? Because this is the radiographic apex, not the anatomic apex. So always follow the anatomic apex, not the radiographic apex. Problems with radiograph. Look to this illustration, this photo. Here we have the premolar, for example, and we put the K file. We take an X-ray. Here the X-ray shows that everything is okay. In my working length, and everything is okay. But when I will see here, this is a perforation. This is over instrumentation, over preparation here. From this photo or from this X-ray, I have to minimize 1 millimeters at least to be sure that I'm in the apical or in the radiograph, not in the radiographic apex. I am in the anatomical apex. Now, problems with radiograph. Teeth with 2 canals, for example, in one root, and canals need shift, PL plan. For example, like premolars, upper premolars, MP root in upper molars, MP1, MP2, and unfortunately sometimes MP3, MP and ML in lower molars, and unfortunately MM nowadays in lower molars. So if I have more than 1 canals in the same plan, I will face a problem when I make a radiograph. Why? I need to make a shift. We will see now. These problems, we have a solution. The solutions, we can say 1 radiograph for each canal. And actually I don't like it. Sorry guys, but I think it's a stupid way, a stupid technique. 1 radiograph for each canal. Oh my god. If I have a teeth with 4 or 5 canals and I will make 1 radiograph for each canal, I will put the X-ray. I will put the K file in the canal, taking an X-ray, remove it, put another K file in another canal, take X-ray, remove it, bring another K file, put in the canal, make X-ray, remove it. What is this? I'm wasting my time. We have another solution, so I don't like this solution actually at all. The second one is technique, shift technique. We know slope rule. It's very useful. For example, have a look to this case. These 2 images for one case, the same case actually. At the left one, we can notice that there is 1 canal in the distal system and 1 canal in the mesial system. Wow, I hope that endo is easy like this. But when we make a shift for this case, we notice that 2 canals in distal and 3 canals in mesial. Slope technique. This is a very useful technique. This is the illustration of this technique. Actually, here is the tooth, and here is your X-ray machine, and here's the film. Slope technique means same lingual and opposite buccal. What does it mean? For example, if I have a tooth here, and here's the film, I put my X-ray machine here, taking the photo without any shift. If I make the shift for example, for the mesial, okay, the same is lingual. What does it mean? The same is lingual. The same I did mesial. So the same is mesial is lingual. So the mesial one is lingual, whereas the opposite one is buccal. And I can this solution is benefit also. We can use we can use different file design or size. For example, here in this case I use different design. Here this is the rotary file, and here manual file, just to know where is the canal, which one is buccal and which one is the lingual. And here in this case, for example, this is an upper first molar with 4 canals, so the X-ray will be kind of difficult. So I decide not to use different design, the same design. All this file is K file, but the different size. 10, number 10, number 15, number 20. Now we will talk something about electronic apex locator, the generation of electronic apex locator, and actually we will not talk too much about the generation. There's a lot of information about this, but we have to know that there are some generation: first, second, third, fourth, no, fourth, fifth. The first generation is depends on resistant type. The second generation of electronic apex locator depends on impedance type. Third generation of electronic apex locator depends on frequency type, and fourth generation of electronic apex locator depends on multiple frequency. Why? Why electronic apex locator? Why should I use it? Why should I buy it? Why should every clinic has an apex locator in it? 5 reasons, guys. 5 reasons we will talk about. The first one is the high accuracy. Very high accuracy. Actually, the accuracy of 90%. This is not my word. This is an article Gordon in New Zealand. You can check these articles. It's high accuracy to have 90% in apex locator. Reducing the radiation exposure. That's very important, guys. The radiation exposure. It's a cumulative effect. So, for example, if I don't have an apex locator in my clinic and I want to do an endo, for example, at the day, 3, 4, 5 cases of endo, every case maybe need at least 3 periapical X-ray radiograph. So I will take maybe more than 20 a day. That's too much. It's cumulative effect. Solve the problem of buccolingual diminution. This is what we talk about. Sorry. This is what we talk about. The solve problems of buccolingual diminution. We have this case, 3 canals in the mesial system. How many X-ray do I need for taking working length for this case if I want to use a single K file in each canal and make X-ray? Too much. Saving time. Well, actually, this is the most important thing in using electronic apex locator. Saving time. As we know, we are dentists. Time is money. That's it. Time is money. So save your time. Save your patient time too. Diagnose the perforations. That's right. If I have a perforation, but I'm not sure if this perforation or the orifice of the canal, I will use my apex locator to check it. For example, I have this orifice, but I don't know if this is an perforation or this the orifice of the canal. I bring my apex locator, put the K file. The apex locator will give me immediately over. It's just 1 millimeter or 2 millimeters inside this spot or inside this orifice, and the apex locator will give me over the red line. That means it's absolutely perforation. The result of endodontics treatment using electronic apex locator are quite comparable, if not superior, to radiographic length measurement. Regarding the rates of acceptable and short cases, wow, that's very impressive actually, and this is not my word. This is a study. And furthermore, in addition to reducing radiographic exposure, electronic apex locators can reduce the rate of overestimation of root canal length. We talk about this, the difference between radiographic apex and anatomic apex. Clinical uses of electronic apex locator. This is my cases using just electronic apex locator and confirm with the X-ray radiographic, but I do trust my electronic apex locator pretty much. This case, upper first molar, lower molar, premolar. This is wisdom teeth, third lower molar. It was very difficult actually. This case was very difficult to take an X-ray because it's too far. Third molar, the wisdom teeth, and this is this case, upper molar, upper premolar, lower molar, anterior teeth, posterior teeth, premolars, whatever. This is the power of electronic apex locator. Now we will move to tactile sensation. It's about feeling the apical constriction with instrument like K-file, number 10 or number 15. Actually, we put the K-file inside the canal. Slowly, we try to feel the apical constriction with the K-file, with your hands, with your fingers. This technique needs a lot of experience, and this is just for with the canal which has apical patency, but can't work with the canal with blockage. Why? Because I need to try to reach to the apical constriction with my fingers, with my K-file, with my feeling. So it's actually, I don't prefer this technique because it needs an experience and not always correct. Paper point test. Actually, this can be method for final checking working length to confirm. And this happened. I can use this after preparation, and it's good in teeth with large apex, or let's say in open apex. This is this photo, for example. This is my working length. I did with yes. This is an open apex case. Here, my working length. And here, if I move forward or beyond the apex, I will see here in 1 millimeters or 2 millimeters blood. So here I can determine the working length. Patient's pain perceptions. When we reach beyond the apex, I mean the periapical tissue, the patient will say, "Oh, painful, feel pain," and this don't need any anesthesia. But actually I don't prefer this method. It has many mistakes and errors. Sometimes, let's say for example, if I'm working in a canine, it's 30 millimeters. I reach to 25 millimeters. The patient say, "Doctor, it's painful, I feel pain." I will stop in 25 millimeters. It's my working length. I will prepare, I will irrigate, I will obturate, I will make an x-ray, I will adapt. Oh my god, what's happened? Why this happened? Because sometimes the patient in the last 5 or 3 or 4 millimeters of the root canal, there is remained pulp tissue, so there is pain, of course. So I actually don't prefer this technique at all. Now guys, I will give you some clinical tips. Clinical tip number 1: don't ever depend on electronic apex locator alone. Remember that electronic apex locator is important and useful with X-ray, but not a replacement. What does it mean? This means if I have an apex locator and I have X-ray in my clinic, I don't like to just use this method just to focus on apex locator, ignore the X-ray, or focus on X-ray radiograph and ignore the electronic apex locator. No, it's not right. The best way is to combine between two methods. I have electronic apex locator and X-ray. So electronic apex locator is important and useful with X-ray. It's not a replacement at all. This is clinical tip number 1. Clinical tip number 2: canal should not be too dry, and canal should not have a lot of fluids. So what I do in my clinic, in my case, I irrigate the canal with sodium hypochlorite, and after that slightly air syringe. That's enough for me. Some guys, some doctors, my friend put a paper point inside the canal to make sure that there is no fluids and take the working length. I don't prefer this wasting time, because nowadays the generation of electronic apex locator can work in a dry or in a fluids. Clinical tip number 3: isolate well, and I will repeat, isolate well, and I will repeat, isolate well. Try to use rubber dam and liquid dam, and don't forget to rebuild the tooth before you start your treatments. Why isolate well? Because we don't want saliva to be inside the canals, we don't want the saliva to be inside the pulp chamber. This is the clinical tip number 3. It's very important. Clinical tip number 4. Each canal has its file size. What does it mean? Look to this case, this photo. The canal is very wide. It's a canine, I think. The instrument must not be too tight and not too loose. If you use, for example, if you used K file number 10 in a wide canal like a canine, the file will not engage the wall. I need the file to engage the wall. Here, the file will not engage the wall at all. And the reading on electronic apex locator will be dancing. It will be like just like this, to the 0 and come back, to the 0 and come back, to the 1 and come back, dancing reading. Why? Because the K file is very tight. It's very loose. It's small size of K file in a wide canal, so it's not good. And if you use a big size of K file in a narrow canal, for example MP2 or MP1, and you use 15 size number 15, we will not be able to reach the apex, and we need to make pressure and pressure and pressure, and absolutely we will have a broken instrument, and that's great. You can refer it to me. Clinical tip number 5. In case of open apex, I prefer to use X-ray and paper point tests. Well, actually guys, in my clinic, when I fix an open apex, I don't like to use my electronic apex locator. Why? Because here the electronic apex locator sometime or often will not give me a good reading, and it will dancing because it's open apex. So here I prefer actually to use X-ray. I put the K file and make an X-ray radiograph, and I confirm the working length with paper point. As we see here, this is the open apex and this is the apex. If you can see it, it's clear, it's obvious under magnification. Here is the test of paper point. You can see here the blood, so here it's an over my working length just to here. This is the X-ray with the instrument. Clinical tip number 6, canal patency. This is very important thing, guys, the canal patency, and it's not just my word, not my opinion. Here's an article's impact of apical patency on accuracy of electronic apex locator in vitro study. This is a very nice study for nearly Abdus Salam, and the conclusion of the study is that the patent canal gives accurate reading, always go beyond the apex and come back. Well, I always do this in my clinic. In all my case, I don't reach to 0 and stop. No, I always go beyond the apex and come back. Try to reach to your destination 0.0, okay, and go beyond the apex, see the red lines and come back. Patency canals is the patency is very important here. Clinical tip number 7. I prefer always to take the working length more than one time. Why? Because if you have, for example, curved canals, during instrumentation you will lose the main working length. For example, I have a curved canals. These canals, I take the working length at the first with scouting. It's 22 millimeters. After preparation with rotary files, I confirm or I check my working length. It's 20 or 21. Why? Because the curvature instrument. So take the working length at the first, scouting, after glide path, and before obturation. Try always to take the working length more than one time. Clinical tip number 8. I'm sorry. Clinical tip number 8. The reading on the screen of the electronic apex locator doesn't give us a measurement or millimeters at all. I have this apex locator, for example. I have the reading 0.0, 1, 2, 3. When I reach to the 1, okay, this is not mean that means that I'm far away from the apex 1 millimeters. No. If I'm on 2, reading 2, it's not mean that I still have 2 millimeters. No, at all. This not mean the millimeters. It's just reading that you are going forward the apex or you are going back 3 2 1 0, it's okay, but doesn't mean any millimeters. The conclusion, the end of this presentation. Apex locator is more accurate than radiograph, but actually we have to combine. The best technique to determine the working length is using combination of more than one method. I said it. You have electron excavator, you have paper point or X-ray. Try to combine between two methods. It's better. Before confirming the working length, check the patency of the canal. Check the patency. It's very important. And apical foramen blockage has a negative influence on the accuracy of apex locator that was more pronounced in root ZX than Rapex 6. This is research. This articles from Nelly Abdussalam in the article. Electronic apex locator is good, but it's not always better than X-ray. Why? Just like open apex, resorptions, and metal crown restoration. In this case, the apex locator will not work well. At the final, guys, electronic apex locator is a magic tool, magic device, but without a good magician, it will not work well. And this good magician is you, the doctors. Finally, thanks for your listening, guys. Thank you.